Welcome to the deep dive. You know, an EMT can stop a heart attack in its tracks, or reverse a fatal drug overdose in just seconds, or even pull someone back from the brink of anaphylactic shock. And they do it using a toolkit that relies almost entirely on manipulating your own body to fight itself.
Right, and it is really the ultimate tension. You have this utter chaos of a medical crisis on one hand, and then the absolute unforgiving precision of biology and chemistry on the other.
Yeah.
There is zero margin for error, but, you are operating in the most unpredictable environments imaginable.
And that is exactly why we are taking this deep dive today.
Yeah.
Because if you're ever the one standing on the sidewalk waiting for that ambulance or trying to help a loved one in a crisis, you really need to know what is actually happening the second they open that medical bag.
Exactly.
So our mission today is to extract the ultimate shortcut to understanding how emergency medications work. We're pulling this from a standard EMT training textbook, specifically Chapter 12, Principles of Pharmacology. We are going to decode the mechanics of saving a human life on the fly.
It's a fascinating chapter.
Okay, let's unpack this.
Yeah.
Because before we even see the flashing lights, we have to look at the invisible chemical battles happening inside the body, right?
Yeah, we have to start with the blueprint of action.
Right.
I mean, pharmacology at its core is just the science of drugs, how they are formulated and how they behave.
Okay.
A medication is simply a substance used to prevent or treat disease or relieve pain. But to wield these tools in a life or death situation, you have to understand the microscopic mechanisms at play.
I noticed there's a really specific language to this, starting just with the names. Like every single drug has a generic name and a trade name.
Right.
The generic name is the simple chemical name, usually written in lowercase like ibuprofen. And you have the trade name, which is the capitalized brand name the manufacturer slaps on it. So, ibuprofen becomes Advil or Motrin.
Acetaminophen becomes Tylenol.
Exactly.
The naming convention keeps things standardized for everyone, but the real fascination lies in what those chemicals actually do once they enter your system. And this is pharmacodynamics.
Right, the process by which a medication works on the body.
Exactly. At the cellular level, these drugs generally fall into one of two camps. They are either agonists or antagonists.
So an agonist is basically like a master key. You slide it into a cellular receptor, which is the ignition, and it starts the car's engine. It stimulates a very specific action in the body.
That's a great way to think about it.
But an antagonist, that is like snapping a key off in the ignition. It doesn't start the car. And because it is physically stuck in the slot, no other key can get in to start it either.
Yeah. Antagonists bind to their receptor specifically to block other chemicals from attaching. They don't actually trigger a response themselves. Their entire job is to just occupy the space.
Wow.
And once that chemical key is in the ignition, we have to look at the flip side, which is pharmacokinetics.
Okay, so if pharmacodynamics is what the drug does to the body, pharmacokinetics is...
how the body fights back.
Right. How the body processes it and eventually gets rid of it.
Yeah.
Yeah.
There is a 4-part life cycle to this. First is the onset of action. That is the time from the moment the drug enters the system until you actually see a clinical effect.
Okay.
Then comes the peak, where the medication achieves its maximum impact. Third is the duration, meaning how long those clinical effects actually persist. And finally, elimination.
Your liver and kidneys metabolizing and basically removing the chemical.
Exactly, which means EMTs can't just hand out medications like candy. They are constantly weighing a ton of variables.
Yeah, like the indications, the specific conditions that actually warrant giving a drug. But then there are the contraindications, which is when a drug would either actively harm the patient or just do absolutely nothing.
And there is a massive distinction here between absolute and relative contraindications.
Oh, right.
An absolute contraindication means you never, under any circumstances, give the drug. But a relative contraindication is where emergency medicine gets incredibly tricky.
Because it's a gray area.
Right. Yeah. The drug might carry severe risks, but, if the patient is moments away from dying, the potential benefits of keeping them alive might actually outweigh those risks.
And even if you make the perfect call, you still have to navigate adverse effects. There's a really fascinating difference between unintended effects and untoward effects.
Right.
Unintended effects are annoying, but generally harmless.
Yeah.
Like a medication giving you a sudden headache or a dry mouth. But untoward effects are actively harmful. They can make the underlying crisis worse.
Exactly.
So factoring in the onset, the duration, the untoward effects, and knowing that drug doses depend heavily on a patient's weight and age, I actually have to push back on the reality of this.
Okay, go for it.
If someone is crashing in front of you, how does an EMT calculate milligrams per kilogram of body weight perfectly? I mean, I can barely do tip math at a restaurant, let alone do complex algebra while someone is literally coding.
Well, the secret is they don't rely on doing complex math in their heads during a panic.
Thank goodness.
Right. The cognitive load in an emergency is already totally maxed out. That is why the system runs on strict protocols and standing orders.
Oh, yeah.
Medical directors have already pre-calculated standard doses for the vast majority of scenarios. The math is done in a quiet office weeks in advance, so the EMT just executes the protocol.
That makes so much more sense. But knowing the exact dose doesn't save a life if the drug doesn't reach the target cells in time, right? I mean, the physical route a drug takes to enter the body basically dictates everything.
It really does. If we have the blueprint of how drugs work chemically, the next hurdle is purely logistical. How do you get it into the bloodstream when every single second counts?
Yeah.
The body has two main categories of highways, basically, enteral and parenteral. Enteral medications use the digestive system. You swallow a pill or receive a rectal administration.
But the digestive system is a winding, scenic route. It's built to break down food slowly, not to deliver life-saving chemicals instantly.
Right, exactly.
Taking a pill orally can take up to an hour to be fully absorbed into the bloodstream. And in an emergency, an hour might as well be next week.
Which is why, to get immediate results, emergency medicine relies on the parenteral route. This bypasses digestion entirely.
And the most famous fast lane there is intravenous or by IV, right?
Yeah. You insert a catheter directly into the vein, giving the drug immediate 100% access to the circulatory system.
Right.
But there is a scenario where IV access is physically impossible. If a patient is in profound shock, their blood pressure just plummets.
Okay.
And when that happens, the peripheral veins in their arms and legs essentially collapse. They just go flat. You couldn't get a needle into them if you tried.
Which leads to the IO route. Intraosseous. I have to admit, reading about this mechanism made my stomach turn a little bit.
It is pretty intense.
If they can't find a vein, they reach the bloodstream by taking a specialized device and literally drilling a needle into the outer layer of the patient's bone to access the bone marrow.
I mean, is that really safe? It sounds absolutely barbaric. It does sound incredibly aggressive, but the biological architecture of bone actually makes it a perfect backup system.
Really?
Yeah. The medullary cavity, which is the spongy marrow inside your bones, is a massive, highly vascular network. And unlike veins, bone is rigid.
Oh, so it can't collapse.
Exactly. It cannot collapse no matter how low your blood pressure drops. So that IO drill creates a guaranteed, uncollapsible highway straight into the central circulation. It is a literal lifesaver when veins fail.
That is wild. But wait, if hitting a vein or drilling into a bone guarantees the drug gets there immediately, why don't EMTs use those routes for every single emergency medication?
Well, context and chemistry really dictate the route. First off, you don't always want a drug coursing through the entire circulatory system.
What do you mean?
Like if someone is having a severe asthma attack, you want the medication acting locally, right? Right. Relaxing the specific smooth muscle tissue in their lungs. Systemic delivery might cause massive, totally unnecessary spikes in heart rate.
I see.
Secondly, starting an IV or drilling an IO takes time, it takes specialized supplies, and it requires a relatively stable physical environment.
Right, which you don't always have on the side of a highway.
Exactly. If an EMT can get the exact same clinical result in 3 seconds using a non-invasive route, they're going to choose the non-invasive option every single time.
And those non-invasive delivery methods are incredibly clever, like the sublingual route putting a tiny tablet right under the tongue. The mucosal tissue there is so dense with capillaries that the medication crosses directly into the bloodstream in minutes, totally bypassing the stomach.
Yeah, or the intranasal route.
Yeah.
EMTs carry this attachment called a mucosal atomizer device, or MA.
Okay.
It snaps onto a syringe, and when they push the plunger, it forces the liquid medication through a microscopic nozzle.
And it turns it into a mist.
Exactly. It shears that liquid down into roughly 30 micron droplets, because instead of a stream of liquid that would just run down the back of the patient's throat and right into their stomach.
Which would defeat the whole purpose.
Right. The atomizer creates this fine mist, and that mist clings instantly to the highly vascular nasal mucosa and absorbs rapidly into the bloodstream and even across the blood-brain barrier.
Wow. And then you have the older reliables. Subcutaneous injections go into the fatty tissue beneath the skin for a slower release.
Yeah.
Intramuscular, like an EpiPen, jabs right into the muscle for quick absorption because muscle has a ton of blood flow. and inhalation gets breathed directly into the alveolar sacs in the lungs.
But you have to remember the route is fundamentally limited by the physical form of the medication itself. I mean, you can't inhale a solid pill.
True.
And there is a really critical distinction to make between injecting a solution versus a suspension.
Okay, break that down for us.
So a solution is a liquid mixture where the chemical is completely dissolved, it won't separate, but a suspension is a mixture containing finely ground particles that will actually settle to the bottom if left alone.
Oh, meaning if you don't aggressively shake a suspension before administering it, you're basically just giving the patient a dose of inactive water while all the actual medicine stays glued to the bottom of the bottle.
Exactly. And in respiratory emergencies, the form matters just as much. You have metered dose inhalers, which require the patient to coordinate their breath with the spray.
Right, like a standard asthma inhaler.
But if a patient is in severe respiratory distress, panicking and gasping for air, they literally can't coordinate that breath.
Yeah, that would be impossible.
So EMTs use small volume nebulizers instead. These use a continuous flow of pressurized external oxygen to turn liquid medicine into a constant mist. The patient just puts a mask on and breathes normally.
Okay, so if we have the highways built and the delivery vehicles chosen, what exactly are we putting on the road? When an EMT opens that bag, what are the actual chemicals going into the body? Let's look at the EMT's toolkit.
Okay, let's start with a metabolic emergency. Dangerously low blood sugar, or hypoglycemia. EMTs carry oral glucose. It's formulated as a gel, but because it's an oral medication, it triggers a completely non-negotiable protocol.
Right, you can never give an oral medication to an unconscious patient or someone whose mental state is so altered they can't protect their own airway. If they lack a gag reflex or can't swallow properly, that gel will bypass the stomach and go straight down their trachea into their lungs.
And aspiration is a lethal complication. Moving to cardiovascular emergencies, EMTs rely heavily on two specific medications for chest pain and suspected heart attacks, aspirin and nitroglycerin.
Let's actually break down the mechanics of these two because they tackle the exact same crisis in entirely different ways.
They do.
Think of a heart attack like a massive traffic jam caused by a pileup in the arteries feeding your heart muscle. Aspirin is given because it inhibits platelet aggregation.
Right.
It fundamentally changes the chemistry of your blood cells, making them slippery so they can't clump together. So it basically stops more cars from crashing into the pileup. But nitroglycerin, it actually widens the highway itself.
Yeah, nitroglycerin aggressively relaxes the smooth muscle in the walls of the blood vessels, causing massive vasodilation. By expanding the veins, it decreases the resistance the heart has to pump against, which drastically lowers the heart's workload and oxygen demand.
Wow.
But because it is such a potent vasodilator, EMTs have to be incredibly meticulous. They absolutely must check a patient's blood pressure before giving it. If the blood pressure is already low, dilating those vessels further will just crash their circulatory system.
And this leads to a really wild chemical interaction. I read that before giving nitro, EMTs have to ask if the patient has taken any erectile dysfunction medications like sildenafil or tadalafil within the last 24 hours.
Yes, because those drugs are also vasodilators. They block a specific enzyme, which leads to relaxed, smooth muscle and increased blood flow. So if you mix them with nitroglycerin, the vasodilation compounds on itself. The blood pressure doesn't just drop, it absolutely plummets to fatal levels. It's an irreversible cardiovascular collapse.
That is terrifying. Shifting from the heart to severe allergic reactions, anaphylaxis. What is actually happening in the body when someone goes into anaphylactic shock?
Well, your immune system severely overreacts to a harmless trigger, like a peanut or a bee sting. It dumps a massive cascade of histamines.
Okay.
These histamines cause widespread vasodilation, so your blood pressure bottoms out, and simultaneously, they cause the smooth muscles in your airways to violently constrict, so you can't breathe and your blood isn't circulating.
Enter epinephrine, usually delivered right into the thigh muscle via an auto-injector.
Right.
Epinephrine is the ultimate fight-or-flight hormone. It does exactly what your body does when a bear jumps out of the woods, but dialed up to 11. It acts on the alpha receptors to forcefully constrict your blood vessels, spiking your blood pressure back up. And it acts on the beta receptors to violently dilate the passages in your lungs. It basically chemically strong-arms the allergic reaction into submission.
It is a systemic sledgehammer. Now contrast that intense physiological stimulation with a medication like naloxone, commonly known as Narcan, used for opioid overdoses.
Okay.
Opioids like fentanyl or heroin bind to the mu-opioid receptors in the brain, which depresses the central nervous system until the patient simply stops breathing.
Right.
Naloxone works because it has a significantly higher binding affinity for those exact same receptors.
Meaning it chemically outcompetes the opioid.
Exactly.
It rushes into the brain and physically shoves the fentanyl off the receptor, taking its place. But because naloxone is an antagonist, like we discussed earlier, it acts like that broken key.
Right.
It occupies the receptor, but doesn't trigger the high or the respiratory depression. The patient wakes up almost instantly.
But there is a massive biological trap here. Naloxone's half-life is often much shorter than the opioid it just displaced.
Oh, wow.
Yeah, naloxone might wear off in 30 to 90 minutes. If the patient had a massive dose of heroin in their system, those opioid molecules are still circulating. Once the naloxone detaches, the opioid slams right back onto the receptors, and the patient goes right back into a fatal overdose.
So you save their life, but they aren't out of the woods at all.
Not even close.
Not to mention, if they are physically dependent on opioids, slamming them with an antagonist instantly triggers severe withdrawal. We're talking extreme agitation, vomiting, and potentially even cardiac arrest. It is a highly volatile save.
It really is. And, we can't ignore the most commonly administered pre-hospital medication of all, which is oxygen. Whether it's delivered through a non-rebreathing mask for severe trauma or a nasal cannula for mild distress, it is treated with the exact same pharmacological respect as epinephrine or nitro. But if we connect all these tools to the broader reality of emergency medicine, there is a sobering truth here. Not a single one of these drugs actually cures the underlying disease.
Right. Epinephrine doesn't cure the peanut allergy. Nitroglycerin doesn't actually remove the plaque from the artery.
Exactly. What they do is aggressively manipulate the body's mechanical levers just enough to buy time. They keep the biological engine running until the patient reaches a surgeon or a definitive care facility.
But handing a provider a bag full of chemical sledgehammers is potentially catastrophic without a strict system of human checks and balances. The medications only work if the human element is flawless.
Which is why EMTs operate under a rigid umbrella of medical control. Sometimes this involves direct online orders where they are literally on a radio with a trauma physician getting verbal permission to administer a drug. Other times, they operate on offline standing orders, those pre-approved protocols we mentioned earlier.
And there are different layers to how the drugs are actually given, right?
Yeah.
It could be peer-assisted, like an EMT jabbing their partner with an antidote after a chemical exposure. It could be patient-assisted, where they're just helping a panicked asthma patient assemble their own prescribed inhaler. Or it's EMT-administered, pulling a vial directly from the ambulance supply.
But regardless of the scenario, they rely on a cross-check procedure called the 9 rights of medication administration.
The 9 rights.
Think of it as a mandatory cognitive pause. Like a pilot's pre-flight checklist, but applied to biology, designed to catch errors before the drug ever leaves the syringe.
Okay, some of these seem incredibly obvious. Right patient, right medication, right dose, right route. Obviously, if you get those wrong, you're going to do harm. But then it gets into things like right time, which means checking the expiration date, right?
Well, expiration is part of it, but it's also about the timing of the dose. Like, did they already take a dose 10 minutes before you arrive? Is it too soon for a second administration?
Ah, that makes sense.
Then you have right education. You can't just silently inject someone. You have to explain what you're giving them and what it's going to feel like, because a sudden rush of epinephrine feels terrifying if you aren't expecting it.
And that ties directly into the right to refuse. I think people forget that if a patient has their faculties and decision-making capacity, they can literally look an EMT in the eye and say, no, I do not want that medication.
Patient autonomy is paramount. Then you have right response sticking around to evaluate if the drug actually did what it was supposed to do. And finally, right documentation, because in medicine, if you didn't document it, it legally didn't happen.
But errors do happen. It's a chaotic environment. What really stuck out to me is how modern EMS handles those mistakes. If an EMT pushes the wrong dose, they don't cover it up. The protocol is strict. Rapidly provide care to mitigate the damage, notify medical control immediately, document it honestly, and debrief with a medical director.
Yeah, the culture has shifted heavily away from simply punishing providers toward analyzing the system. If an error occurred, was the lighting bad? Were the vials packaged too similarly?
Right.
High-stakes medicine requires a culture where people feel safe reporting their mistakes. Otherwise, those exact same mistakes will eventually kill someone else.
And there's one final variable in this human element, and it's the one the patient themselves brings to the equation: polypharmacy. The reality that most people are already walking around with a cocktail of prescription drugs in their system. If I'm ever in a situation where I'm helping an EMT with a loved one's medical history, what am I most likely to forget to tell them?
It's almost always the things you don't consider real medicine. Herbal remedies, vitamin supplements, over-the-counter cold medicines. Anything pharmacologically active can interact with an emergency drug. Or, perhaps more dangerously, people forget to mention non-compliance.
Meaning the patient stopped taking their meds.
Exactly. Or, the reverse, they took a massive dose of a beta blocker. Let's say a patient is in a car crash and bleeding internally. Normally, their heart rate would skyrocket to compensate for the blood loss.
Right.
But if they are on a heavy beta blocker, their heart is chemically capped. It cannot beat faster. An EMT might look at a normal heart rate and entirely miss the fact that the patient is in profound hemorrhagic shock. Controlling the controllable, getting an insanely accurate history is the only way to navigate this safely.
Man, let's zoom out and summarize this. We started at the cellular level with pharmacodynamics, looking at how agonists and antagonists act as master keys or broken keys in our receptors.
Right.
We mapped out the highways of the body, from the slow, winding roads of the digestive tract to the brutal but life-saving fast lane of an intraosseous bone drill. We opened the EMT's toolkit, exploring how aspirin, nitroglycerin, and epinephrine violently manipulate the body's mechanics just enough to buy time. And finally, we looked at the rigid human checklist that govern it all.
It is a beautifully complex system, but it leaves me with a philosophical question to consider.
Oh, what's that?
This entire structure is built around highly trained professionals administering these interventions. But look at society today. EpiPens for allergies, intranasal naloxone for overdoses, automated external defibrillators. These tools are now widely distributed. They are in high schools, coffee shops, and people's backpacks.
Yeah, the line between bystander and first responder is completely disappearing.
Precisely. If the tools of emergency pharmacology are no longer just locked in the back of an ambulance, but are literally sitting in your own pocket, what does that mean for our societal responsibility to one another? When someone collapses, we are increasingly equipped to be the ones manipulating those chemical levers.
When that biological crisis hits, whose job is it to intervene? That is a profound question to chew on. Thank you so much for joining us on this deep dive into the high-stakes world of emergency pharmacology. Until next time, stay curious, stay informed, and we'll catch you on the next one.